Hello everyone. So today we are going to discuss maternal pelvis and fetal skull. Okay, this is a very easy topic. Okay, and very easy questions come from this topic. Though they come less often, but all the questions which come on this topic are very easy. Okay, so you just focus for few minutes and you will come to know that all the questions were asked in such a simple way that if a question come from this topic, then you are the lucky one. As we are doing this topic for the first time, we will do in the same pattern we were doing the before. First we will see the questions will come from which topic, and then while explaining it we will discuss the topic. Okay, so let's start. So this is a question from FMG December 2020. Let's see what is it. A line drawn from the mid part of the mid part of the posterior surface of the symphysis pubis. So here we have to draw the line from the posterior surface of the symphysis pubis. Now this we have drawn the line from the posterior surface of the symphysis pubis to the tip of sacral promontory. So this is the sacral promontory, to the tip of the sacral promontory. So this is pubic symphysis posterior part. They have told that we have to draw the line from the mid part. So from this point to this point. So this is a red one line which has already been drawn. This red line. Okay, this red line. Now what diameter is this? Okay, they are asking what is the name of the diameter. The pubic symphysis mid part going to the sacral promontory tip part. Okay, let's see. Now see, this is the maternal pelvis. Maternal pelvis is divided into three. Okay, for example, if we have a cylinder like this, then this cylinder has three parts. It is inlet, right, outlet, and the cavity inside. In the similar way, the maternal pelvis also has three parts. Okay, so you can see these are it. This is the inlet. I'm drawing the inlet now. Okay, this is the inlet of the maternal pelvis. Okay, so this is the sacrum bone promontory. Okay, and all the pelvis which is above this is the, what is this? This is false pelvis. Okay, false pelvis, and the pelvis which is below this inlet is the true pelvis. Okay, now it has three parts. This is inlet, okay, and this is outlet. See, I'm drawing how much I can draw. I will draw. Now I'm erasing the inlet. So here it goes up till coccyx. See, okay, so these lines when they meet at coccyx, okay, they meet by the sacrotuberous ligament, and that is known as outlet. So this is outlet. What I have earlier drawn was inlet. This is inlet. Okay, and the cavity which is between both of them is the pelvic cavity. Okay, cavity which is between both of them is the pelvic cavity. Now we will see the diameters. Okay, so now you can see that this is inlet. Okay, so in the inlet here posteriorly it is the sacral promontory. This is the sacral promontory. Interiorly it is the pubic symphysis. This is pubic symphysis. Okay, and here laterally these are the iliopectineal lines. Okay, now we will see the inlet diameters. Okay, now this is the inlet we have seen. Okay, now this inlet will have diameters. As you can see that this is circular, right? This is circular in shape. Okay, this is somewhat circular in shape, right? And now this is the antero-posterior diameter. Okay, the line which has gone from anterior to posterior is known as antero-posterior diameter. Okay, okay. Now similarly, if a line is going transversely, then it is the transverse diameter. This blue line is the transverse diameter. And the line which goes oblique is the oblique diameter. Then the line which goes oblique is the oblique diameter. So this is the oblique diameter. So this is it. If we draw it here, this is antero-posterior diameter, this is transverse diameter, and this is the oblique diameter. So this is the antero-posterior, this is the transverse, and this is the oblique. Okay, okay. So these are the three diameter. So let us talk in detail about the antero-posterior diameter. Okay, so we are going to talk now about in detail about the antero-posterior diameter. Okay, so let's see. Now this is of course the antero-posterior diameter, right? It sacral promontory to the pubic symphysis upper part. Okay, and this is known as anatomical conjugate. Okay, anatomical conjugate. This is known as anatomical yes, this is known as anatomical conjugate. Okay, this diameter is known as anatomical conjugate. Okay, okay. Now we cannot measure this diameter practically. We cannot measure this diameter practical. Can we measure it? No, we cannot measure it, because a lot of organs and lot of muscles are there inside the pelvis. We cannot measure it how much long it is, but we need to measure. For doing the pelvis assessment, we need to measure. So let's see what we can measure. Okay, we can measure this diameter. We can measure this diameter. See this diameter, the one which is at the lower end of the pubic symphysis, lower end of the pubic symphysis, and going up till tip of the sacral promontory, going up till tip of the sacral promontory. See, now this is the lower border of the pubic symphysis, and the finger is going up till the tip of the sacral promontory, and this is measured. Okay, so we can measure this diameter. See, we have measured diagonal. So the one which we can measure is the diagonal conjugate, is known as diagonal conjugate. This lower part of the pubic symphysis to the tip of the sacral promontory. Why we say it diagonal? Because we put the finger diagonally. Okay, because we put the finger diagonally. See, I am putting the finger diagonally, right? So because I am putting the finger diagonally, and this is known as diagonal conjugate. Now the pubic symphysis is, see, this is the pubic symphysis bone. This is elevated from the mid like this. So the diameter which was going from the upper part of the pubic symphysis to the sacral promontory is the anatomical or the true, because that is what the anatomy of the pelvis has given us. The diameter from the lower part of the pubic symphysis to the sacral promontory, which we can measure, is the diagonal, because here we place the finger diagonally, and this from the mid part of the pubic symphysis to the Sacral promontory is known as obstetric conjugate. Why it is known as obstetric conjugate? Yes, because it is very narrow, because mid part is elevated. As you have seen that the mid part is elevated. See, this mid part is elevated. So it is most least less diameter. Okay, and and you know that a head has to go through this diameter of the fetus head, it has to go through the pelvis. So this diameter creates obstruction. Okay, so this diameter creates obstruction, so it has its obstetric relevance. That is why it is known as obstetric conjugate. Okay, so the diagonal conjugate is 12 centimeter in size normally, and anatomical conjugate is 11 centimeter, and this obstetric conjugate is much lesser, 10 to 10.5 centimeter. Okay, so our question was, what is this diameter called, which is from the midpoint or to the sacral promontory? So this is obstetric conjugate. The answer was obstetric conjugate. So it is simple. Diagonal is known as diagonal because here we put the finger diagonally. This is known as anatomical or true conjugate because it is what the anatomy has given us, and this is known as obstetric conjugate because it is very less in its size, and it creates problem for the fetus and has its own obstetric relevance. Okay, now still if any one of you want mnemonics, the mnemonics are DOT, but here you have to remember they are down to up. So D stands for diagonal, O stands for obstetric, and T stands for true or anatomical conjugate. So this is 12 centimeter diagonal. Obstetric is 10.5 least diameter, and the true or the anatomic is 11. Okay, because we can measure this diagonal conjugate, so we can derive the other diameters also. For example, a lady has on an average 11 centimeter diagonal conjugate. We measured it by the finger and we found that it was 11 centimeter. Then and anatomical is 11 minus 1, that is 10. Anatomical will be 10 and obstetric will be 9.5. Okay, minus 1.5, this will be obstetric. Okay, so that was all. How we are going to to calculate the anatomical, we are going to deduct minus 1 centimeter, and to calculate the obstetric conjugate, we are going to minus 1.5 centimeter. That is how we can calculate. Okay, so that was about the inlet antero-posterior diameter. Okay, this was the inlet, that was about the inlet antero-posterior diameter. Or of course this inlet has transverse diameter and oblique diameter also, but they are not of so relevance, so we are leaving it here only. So this is a question from NEET PG 2022. NEET PG 2022, they told to identify the green shaded area. Here we have to identify the green shaded area. So this is the green shaded area. It is a recent question, so chances are there that question from this topic will come in your exam. Okay, so focus. Okay, see, now here I would like to tell you that the cavity that we studied, that there was a pelvis which has the inlet. There was the pelvis, which has the inlet, which had the outlet, and in between was the pelvic cavity. Right? Now that pelvic cavity has four planes. Of course, one plane is plane of inlet, okay, and the another plane is plane of outlet. The another plane is plane of outlet. Okay, these are the two planes we have studied. Now two more planes are there in between, like this. Okay, now we will study those planes. Okay, so let us see they are the name of them is plane of greatest dimension and plane of least dimension. See here, now this was the inlet, sacral promontory where it was going, right, plane of the inlet, and this which is from the mid part of the pubic symphysis, goes from mid part of the pubic symphysis up to S2 S3. This is the plane of greatest dimension. This is the plane of the greatest dimension, and it goes from mid part of the pelvis pubic symphysis to the S2 S3. Okay, and this which is from the lower part of the pubic symphysis to the S5, okay, is the plane of the least pelvic dimension. So this is the plane of least pelvic dimension, and this is the plane of the greater pelvic dimension. Okay, this is the plane of the greater pelvic greatest pelvic dimension. Okay, got it? Okay, so now here it is, we will look here. So this diagrammatically they have drawn the plane. Okay, so you can see that was a that was a rough presentation. See, this is the inlet plane which goes from upper part of the pubic symphysis to the promontory. This is the greatest pelvic dimension plane, right, which goes from S2 S3 to the mid part of the pubic symphysis. Here it is very roomy, pelvis is very roomy, and this is the plane of least pelvic dimension where it is from the lower part of the pubic symphysis to the S4. Here you can see here in this diagram there are ischial spine. Ischial spines are there. Okay, and this is the plane of the outlet. This is the plane of the outlet. It is somewhat curved because as you have seen here in this diagram, see, it is curved, then it goes straight. So here also it is curved, first it comes down, then it goes straight. Okay, so now the space between the plane of the greater pelvic dimension and the least pelvic dimension, this space is known as mid pelvis, is known as mid pelvis. Okay, and that was the question here. Okay, ki what is this green shaded area? So this is, as you can say, it is originating from the mid part of the pubic symphysis and ending at the lower part. So this is mid pelvis. Answer to this question is mid pelvis. Let me show you this between the greater pelvic dimension and least pelvic dimension. This part, it is known as mid pelvis. These two planes have divided the whole pelvic cavity into three spaces. The mid space is known as the mid pelvis. Okay, now let's see the other option. They have given first option is inlet. No, what is inlet? Now you all know that from sacral promontory to the upper border of the pubic symphysis. Then another is obstetric outlet and anatomical outlet. Now what are these? Anatomical outlet and obstetric outlet. Now this outlet is the anatomical outlet. This is the anatomical. This is the anatomical outlet. And what is obstetric outlet? This space between the least pelvic dimension plane and the outlet plane. Let me change the color. This space, this cavity, this segment of the pelvis, which is between the plane of the least dimension and the outlet, this is known as the, this space below, this is known as the obstetric. This part of the cavity is known as the obstetric plane. Obstetric plane. This segment of this part is known as the obstetric plane. So obstetric outlet is wrong because obstetric outlet is this. Okay, this is the mid pelvis, this is inlet, and this is the, you can say, anatomical outlet. So this is the mid pelvis is the answer. I hope you understand. Okay, now after dividing this, we have seen that this was the plane of the greatest pelvic dimension and below is the lowest pelvic dimension. So the space between greatest and lower pelvic is, this is mid pelvis, and this space between the lowest dimension and the plane of anatomical outlet is this cavity is known as obstetric outlet. Now you know both the differences, the difference between the anatomical conjugate or the obstetric conjugate, and now you also know the difference between the anatomical outlet and the obstetric outlet. Okay, now you should know that one thing very fairly, conjugate means inlet diameters. Conjugate means inlet diameters. Okay, so let's go to the next part. So see here that now we are going to see the diameters. Okay, diameters. One diameter of this pelvis cavity is very important, and that is the diameter between the spines. Okay, diameter between the spines, and that is the interspinous diameter, and it is the transverse diameter of the pelvic cavity, and it is normally 10 centimeter. Once again I want to tell you, there we learn the AP diameter of the anterior-posterior diameter of the inlet we learn, right? There we learn the anterior-posterior diameter of the inlet. The important diameter of the inlet was the anterior-posterior or the conjugate diameter. Okay, and of the cavity, the diameter which is important is transverse. Okay, and the transverse diameter is, normally it is 10 centimeter. It is the most narrow space of the pelvic cavity. Okay, it is, see, this is and as you have seen that here only the as you have seen that from here only the what was passing, yes, what was passing at the level of the ischial spine only. See, at the level of ischial spine was plane of least pelvic dimension, because due to this ischial spine only there was the narrow dimension, less dimension. And so this diameter is also important because it is the most smallest diameter of the pelvis, which is 10 centimeter. Okay, now see here. Midwife at a PHC did PV. Now this is a question. Midwife at a PHC, midwife at the PHC did the PV and of a woman in labor. The patient was in labor, and the findings are 8 centimeter cervical dilatation, 70% effacement with fetal head at +1 station. The question was, what does this +1 station means? Okay, so as I already told you that this plane of least pelvic dimension, or this diameter or interspinous diameter, is very important. So now let's see what is the relevance of interspinous diameter. What is the relevance of interspinous diameter? So the answer is internal rotation occurs at this level. You all know a procedure of labor is in a step of labor is internal rotation. Head gets flexed, supposing that this is the fetus, the head has got flexed, right, and then the head goes down, descent, and then there is internal rotation like this. If this is the anterior posterior, okay, head, then it gets like this, rotate, internal rotation. So this internal rotation occurs at the level of the interspinous diameter. Okay, okay, okay. And next is this ischial spine. If the head has come to the ischial spine level, it means that it is at the 0 station. If it is above, it is 1 centimeter above, it is known as -1 centimeter. If it is below this ischial spine, then it is known as +1 centimeter or +1 station. Okay, okay. So let me draw here. See, if this is the pelvis, if head is here at the ischial spine, so we should know now when deliveries where are the head, where is the head in the delivery, whether it is down or whether it is up. So we measure it from the ischial spine. Here ischial spine is the 0. We mark the ischial spine as 0. Above 1 are the -1, -2, depending on how many centimeter it is above, and downward are the +1, +2. If head is here, we will say it is at a +1, +2. So here the midwife write it as head at +1 station. It means it is below this ischial spine. Head is somewhat like here, 1 centimeter below. So the answer is 1 centimeter below the ischial spine. Other questions or other one-liners on interspinous diameter is that first of all, this ischial spine, they represent the station, and internal rotation occurs at this level, and external os lies at this level. Okay, external os, it lies at this level. Most cases of deep transverse arrest, because this is the most smallest diameter, so deep transverse arrest occurs here. Okay, so arrest will occur at a narrow position, right? Okay, next is marks the beginning of forward curve. So first, how the pelvis is there? So first pelvis is going backward, and then the pelvis cavity goes forward. So like this. If we draw a plane, so the pelvic cavity goes backward. See, it is going backward. Okay. Then at the level of the ischial spine, it turns forward. Okay. First the fetus go downward, then this fetus have internal rotation, and then this fetus come forward. So it marks the beginning of the forward curve. In the starting, I tell you that here is internal rotation occurring, because here the levator ani, the main muscle, it originates. The levator ani, the main muscle originate, and this is the landmark for the pudendal block. Now let's go to the outlet. So this is the outlet. We are seeing the pelvis form downwards. See, pubic symphysis, ischiopubic rami, sacrotuberous ligament, coccyx, again sacrotuberous ligament, and this is again ischiopubic rami. So this is the outlet, and here the transverse diameter is important. Transverse diameter, this, okay, this is between one ischial tuberosity to the another ischial tuberosity. So this transverse diameter is also known as bituberous diameter or intertuberous diameter, and it is 11 centimeter. Okay, once again I'm telling you, antero-posterior diameter of inlet or the conjugate was the diagonal conjugate was 12. ठीक है, interspinous was 10, and the this was the transverse diameter, and the transverse diameter of the outlet is 11. So 12, 11, 10. But here you have to see that this is antero-posterior. Yes, so here you have to see that this is antero-posterior, or it is 12, and here transverse is 10, and here transverse is 11. Okay. Okay. Now we will see what is contracted pelvis. If the we will measure these diameter. Now, if they are less than certain limit, then it is known as the contracted pelvis. It means the pelvis are of the less dimension than they should be. So normal delivery will not be possible if these diameters they are less. Okay, let's see. They say that if obstetric conjugate, so we were measuring their inlet obstetric conjugate, we were measuring diagonal conjugate. So diagonal conjugate minus 1.5 was obstetric conjugate. So 12 minus 1.5 is 10.5. But if this obstetric conjugate is less than 10, then we say it a contracted pelvis. And if the interspinous diameter is less than 8, it is known as the contracted mid pelvis. And if this outlet is less than 8, then again it is known as the contracted outlet. So this is again bituberous, and this was a interspinous diameter. Okay, so these are the dimensions. If the values are less than these, then it is known as a contracted pelvis. Let me tell you how we will measure. See here, here we are measuring diagonal conjugate. We are doing the PV, touching the one border of the our this finger to the pubic symphysis lower border and feeling the promontory like this. So we are putting the finger diagonally, and we will mark the point where we felt, and then we will measure this distance with the scale. Okay, so everyone knows, every obstetrician knows what is the distance. Okay, so accordingly we can see. And this is how we will measure the transverse outlet diameter, the diameter between the two ischial tuberosity. So if this fist goes inside that ischial tuberosity, means it is sufficient or it is more than 8 centimeter. This fist size is 8 centimeter. Okay, so if the fist goes then it is the diameter is, outlet diameter is not contracted, it is sufficient to let the delivery proceed. Okay, now how we measure the interspinous diameter? See here in the camera, we put the finger inside the pelvis and we do it like this, and then we feel the both the ischial spine. If we are not going to feel both the ischial spine simultaneously, it means that the ischial spine are far. It means the ischial spine are far. See, I can maximally dilate it like this, and this is around around 7 centimeter. So if I am able to feel both the ischial spine, it means the mid pelvis is narrow. Okay, if I'm not able to feel, it means it is roomy to let the delivery occur. Okay, okay. Now let us see, that was about the maternal pelvis. Is now let's see the fetal skull. Okay, so this is the fetus skull. Now we will see what all we have to read here. Now first of all, on the fetus skull we have a interior fontanelle. See, this is interior fontanelle, and here it is the posterior fontanelle. Okay, so this interior fontanelle is also known as bregma, and the posterior fontanelle is also known as lambda. Okay, posterior fontanelle is also known as the lambda. Okay, and this interior fontanelle is also known as the bregma. Okay, so these 2 points you have to remember. Okay, now let's see the question which comes. What is the position of the fetus shown here? They have asked the what is the position of the fetus. To answer this, we have to learn different things. Now let us see the definition of the presentation. What is the definition of the presentation? Definition of the present. What do you mean by presentation? Presentation means the which fetus part is in the lower uterine segment. Okay, if this is the uterus, if this is a uterus, so which fetus part is in the lower uterine segment? If this is the fetus and this is the uterus, which part is in the lower uterine segment? It can be head, it can be pelvis. If it is head, then we will say the presentation is cephalic. If it is a breech, then we will see the presentation is breech. Okay, pelvis. If there is a pelvis part is in the lower part of the uterus, then it is the breech presentation. So which part is coming? Okay, if shoulder are coming in the lower part of the uterus, then it is the shoulder presentation. Okay, so which part of the fetus is coming in the lower uterus, lower part of the uterus? If head is coming, then it is cephalic. If pelvis is coming, then it is breech. If shoulder is coming, then it is shoulder presentation. Okay, okay. Now, presenting part. What do you mean by presenting part? That we studied was presentation. What do you mean by presenting part? Okay, let me tell you. Now you are seeing here in this diagram, in this all this 4 diagram, what is the presentation? Which part is in the lower uterine segment? You can see here also it is cephalic. Here also it is cephalic, and here also it is cephalic, and here also it is cephalic, and here also it is cephalic. So head is presenting here in the all the parts, right? Head is presenting here in all the parts, but here the here the neck is flexed, here it is deflexed, right? And here it is extended. So now you always remember, in some conditions the delivery is easy and in some conditions the delivery is difficult. As an obstetrician, we just have to tell the patient that your delivery is easy and difficult, so the patient get mentally prepared, and in which condition delivery is not possible. Okay, so how we will name this all these conditions? Presentation in all this condition is cephalic. So you can see here that in all this condition the lower part of the head is different. Okay, so here the lower part of the head is this, and in here the lower part of the head is this, and here the lower part of the head is forehead, and here the lower part of the head is face, right? So presenting part is part of the presenting part felt on PV. What we are feeling on PV? PV is done here, right? PV we do in the lowermost part. In during the PV we feel the lowermost part. Okay, the part which a obstetrician feel on PV is known as the presenting part. Part of the presentation. Part of the presentation, and part of the presentation. Here it should come presentation felt on PV. Part of the presentation, part of the in the cephalic presentation, which part of the head is being felt on PV. So here this is our fetal skull. So we divide this fetus into three parts. We divide this head of the fetus into three parts. This whole part in which the part of face is there, this is known as the face. Okay, this part is known as the one which has forehead is known as the brow presentation or brow presentation, whatever you say. Okay, and this is the this between the anterior and posterior fontanelle is the vertex. Okay, so we divide the head of the fetus into three areas. Okay, the part where this, see here in the camera, where nose and lips are, this part is known as the face. This forehead part and utna hi upar in the same area, this forehead part plus this area we go behind, this is known as brow, and below and between the interior and posterior fontanelle, this is vertex. Now which part is going to present on PV or which part is felt depend on how this neck is flexed. What is the attitude of the fetus? Attitude, what is the attitude? Whether the fetus is a decent fetus or whether the fetus is a egoistic fetus. Okay, see, when the fetus is will be decent, then it will be flexed. See, when we do the PV, we feel this top part. When the fetus is flexed, so then we are going to feel the vertex. Then we are going to feel the vertex. Okay, see, I'm doing PV. Suppose I'm in the pelvis, my head is in the pelvis, I'm the fetus head. So if it is flexed, then I will feel the vertex. Now if I'm deflexed or normal position, then I will feel the brow. And if my neck is extended, then you can see that PV fingers are not moving, then one will feel the face. So what is the presenting part? It will depend on the attitude, whether the fetus neck is flexed or deflexed or extended. Okay, that part will be filmed. That depends on the attitude or on the flexion of the neck. So you can see here in the picture also, if it is flexed, then vertex is there. Then we feel this between the anterior and posterior. If it is deflexed, then brow presentation, and if it is extended, then we feel the face. So these are the three presentation of the presenting part of the cephalic presentation: face, brow and vertex. Okay, now question was, what is the position of the fetus shown? What is the position of the fetus? Here you have to learn few more things to tell here. Okay, now let us see here. Now what do you understand by position? So here I would like to tell you, in the flexed position, the delivery is in the flexed neck, the delivery is very easy. Okay, now here we will see what do we understand by position. Okay, now you are seeing that here in the diagram, all are flexed, all fetus are flexed, right? You can see here all the fetus neck are flexed, right? But all these fetus are in different position. You can see here the back is on the left side, here the back is on the right side, here the back is anterior, right? So now we have to tell what all positions are this. How we will tell? We cannot tell it by back, because back is not something we can feel on PV, or back is not something that we can clearly tell. Okay, we can only tell the things which we feel on PV, that yes, this is this part, this is this part, and on PA it is all estimated, right? So out of all these positions, you see that there are 6 positions of vertex. Okay, out of all these 6 position, out of all these 6 position, there are some positions in which delivery is very easy, and there are some positions in which delivery is very difficult. So as a obstetrician, we have to identify the positions in which the delivery is easy and in which the delivery is difficult. That is our job. And to identify the positions in which delivery will not occur, we need to do cesarean. That is our job, right? So now just see here how to identify the position in which delivery will be easy. First of all, we need to know how to identify the position. So on the presenting part, so we are discussing the most common vertex presentation. On the vertex presentation, we assign a fixed bony point, so that we don't say ki, yeah, that for example, if this is vertex, this area is vertex. See, this area was vertex, right? Right. This we are feeling on PV. So we will give a point. Okay, a bony fixed point. So if we are telling it that it is left position, it means that fixed point, it is in the left position. That fixed point is in the left position. See here. Denominator is we have assigned a fixed bony point on every presenting part. In the vertex, we have fixed occiput. Okay, for example, see here. This is the vertex presentation, right? This is the brow. Oh, these both are brow and this is face, right? These both are brow and this is the face. Okay. Now this is the pelvis left and this is pelvis right. Okay, now here we have to see where is the occiput. Here we are feeling this, we can feel the anterior and posterior fontanelle. Okay, anterior, this is the anterior fontanelle and this is the posterior. So it means that this is the posterior fontanelle. It means occiput is here, occiput is here, right? Occiput is here. Okay, so occiput is in the left. Okay, so that is how we are going to tell the all the positions. So that is occiput is in the left and it is the transverse also. So here we will say a left occiput transverse. See this position. So left occiput transverse. So all the doctors, all the obstetrician will always to tell the position will always tell where the occiput is, because we have assigned the denominator bony fixed point as the occiput on the vertex presenting part. Okay, so occiput, here the occiput is left occiput posterior. Occiput is in the left side plus it is posterior. Okay, and now we will define the position by telling where occiput is in the pelvis. And with respect to pelvis, we have to tell whether it is in the left side of the pelvis or right side of the pelvis. Anterior, posterior, left, right. Okay. Okay. Now the question was this. What is the position of the fetus shown? Okay. Now this is occiput. This is occiput. We have to tell where the occiput is. This is sacrum. Yes, this lower one is sacrum. Yeah, and this is pubic symphysis. So to tell the position, we have to tell the where is the occiput. Now we have seen that occiput is interior, right? Occiput is interiorly, right? And this is the left of the pelvis and this is the right of the pelvis. So this is occiput is in the left interior, sorry, right interior. So this is right occiput interior. Okay, the answer to this question is right occiput interior. And of course this is the vertex presentation, because interior and posterior, the area between the posterior and anterior fontanelle, this area is vertex presentation. Okay. And what is the presenting sorry, what is the presenting part? Presenting part is vertex. And what is the presentation? Presentation is cephalic. Okay, and position is right occiput. So that is how you are going to label it. Which is the most common occiput posterior position? Which is the most common occiput posterior position? The most common occiput posterior is right occiput. Usually, which is the most common position? Just leave this occiput. Is the left occiput anterior or left occiput transverse. This is the most common. Occiput posterior is a abnormal position, and out of all the occiput posterior, what is the most common occiput posterior? It is right occiput posterior. Okay, so these all are the 5-year PYQs that you have to remember. That most common of all, or most common favorable position is left occiput anterior or left occiput transverse. Occiput posterior is a malposition. Okay, so most common malposition is right occiput posterior. Question do come on this. Okay, presenting part of the fetus in left occiput anterior. So this is a FMG question. All those who says in FMG's pelvis does not come, see it is coming. Presenting part of the fetus in LOA. LOA is left occiput anterior. So if this is pelvis, it means the occiput. We mentioned the occiput like this. Okay? Yes. So sorry. Yeah. We draw the if this is pelvis, okay, so and this is anterior and this is posterior, right, and this is left and this is right, okay, of the pelvis. So this is left occiput posterior. Occiput is marked by here. So if occiput is here, it means posterior fontanelle is here, anterior fontanelle is area. The area between anterior and posterior fontanelle is vertex. So vertex has 6 position. Out of this, 1 position is left occiput anterior. Okay. In fetus with well flexed head, the presenting part is, in fetus with well flexed head, the presenting, it should be diameters. Okay, so what are the diameters? Let us see. Now see, when it is the vertex is the presenting part, then the diameter is suboccipito-bregmatic. Suboccipito-bregmatic. See here. Now this is the vertex is presenting here. The anterior and posterior fontanelle are the area is presenting. Now here this is suboccipito. The area which has entered the pelvis is this. Okay, so the but which area, which diameter it enters? This is the fetal skull. Yes, this is the fetal skull. Okay, if it is fully flexed, then which diameter has entered? Can anybody tell here? This is suboccipito-bregmatic. This diameter is entered the pelvis. Okay, you imagine that here it is a pelvis. This line is pelvis line. So suboccipito-bregmatic. So in the vertex, which diameter enters? suboccipito-brachmatic, which is 9.5. So the diameter from subocciput to brachmatic is known as suboccipito-brachmatic. When it is a brow presentation, this is the brow area, this is the brow presentation. What is the diameter? The diameter is, yes, manto vertical. Okay, diameter is, see, this is entering the, this manto. Engaging diameter means the diameter which enters the pelvis. When the fetus descends, then the diameter which enters the pelvis is known as the engaging diameter. So here you can see that these are the diameters which will, I will draw the pelvis like this. Okay, these are the diameters which are entering. Okay, so these two are brow, this is vertex, and this is face. In the case of the vertex, what is entering? Suboccipito-brachmatic. So what is entering is suboccipito-brachmatic. Okay, in the case of the brow, what is entering? Here it is, in this condition is manto, and this point on the head is known as vertical, manto vertical, right? And here it is submento, this point is vertical, submento vertical in the face. So in the vertex presentation it is suboccipito-brachmatic, and in the brow suboccipito-brachmatic, and in the brow presentation it is manto vertical. See, manto vertical. And in the case of the face presentation it is manto vertical, submanto vertical. Okay, so we will see it here. So in the vertex it is suboccipito-brachmatic, which is 9.5. It is very easy. You just flex your hand and see what will be entering. Anterior posterior diameter enters. So this is suboccipito, and make an imaginary line like this, suboccipito, and this is brachma, suboccipito-brachmatic. Then you deflex. This is what will enter when we deflex like this. Deflex your head, manto or vertical, and then extend your head. So this is submanto vertical. Okay, so submanto vertical is this. So here only two questions are asked. Here they have asked, with well flux head the presenting diameter is suboccipito brachmatic, and in the longest diameter, which is 14 centimeter, in the brow presentation manto vertical, here we do cesarean, because it is such a long diameter that it cannot pass, fetus cannot pass through the pelvis in this position. Okay, now this is a list about the transverse diameter of the fetus. Okay, the transverse diameter of the fetus. So now we studied the vertical diameter of the anterior posterior diameter of the fetus. Now we'll study the transverse diameter of the pelvis. So the mnemonic for it is mother tongue superpower. Mother tongue superpower. So bimastoid is these areas behind the ear, bimastoid. Above them is temporal. Imagine my head as a fetal skull. This is the bimastoid. See, this is smallest, then this is bitemporal, then this is subparietal, and this is biparietal, the longest diameter. So biparietal, subparietal, temporal, mastoid. This diameter decrease like this. So the mnemonic is mother tongue superpower. Mother stands for mastoid, tongue stands for temporal, super stand for subparietal, and power stand for biparietal. So biparietal is 9.5 and bimastoid is 7.5. So the shortest diameter is bimastoid. Okay, that was all about the maternal pelvis and fetal skull. So see you soon in the next video. Thank you.